Hello, my name is Robert Polk, and this is Clinical Statement 3 over the time period of February 24th to March 17th. So, over the last 3 weeks, I've collected 29 and a half hours at Indiana State men's basketball with Connor Burton. And I will update you on the honors thesis that I've been working on. So, since the season has officially ended as of March 7th, we have run our analysis of costs and developed the total worth of the services within the 7-week period. So, within this 7-week period of collection, we have raised about $19,425. Considering this is an in-season cost and the season runs for 17 weeks, that would put our total cost of services, if we extrapolate the data, to be $47,177 approximately for the 17-week season. So if we say that 7 weeks that we collected is representative of the entire season, we have provided services that would be in rival to the majority of athletic trainer salaries at $47,000. Within this breakdown of the 7-week period, about 50% of this worth came from the treatment and rehab, about 36 came from prevention, and 14 came from evaluation. So, I would say that 14% from evaluation is really good for in season 7-week period of the middle of conference season for college basketball, and that has potential to grow, which would then increase probably the treatment and rehab, and while decreasing some of the prevention aspects. So I guess going forward, I begin to write my paper and just continuing to work collecting this off-season data now, so that when we finish collection and the semester in May and I graduate, I will send this to Connor, who will be trying to A, get an establishment of what his services are worth, and B, try to get the job hopefully at Indiana State. So from there, I'll transition to kind of the strengths and weaknesses of this past 3-week period. So the first strength that I want to talk about is the standardized patient encounter that Connor put on with the cervical spine management. So from this encounter, I really got to understand what my role would be as the secondary provider. So Connor had assumed the head, and then I did the accessory evaluation, so assessing vitals, including heart rate, breathing rate, respiration rate, blood pressure, distal artery function, so distal pulses, and then a dermatome and myotome of the patient. With this patient, it was more of some numbness and tingling into their legs with neck pain, but no diminishing dorsal pulse, dorsal pedal pulse, and no erratic heartbeat or erratic respirations, and blood pressure was approximately normal. So based from this, after that incident, we notified the director's athletic training services, and then from that, this situation would have also called for calling the director of medical services for the university. So really got the experience of providing those services and then reporting those services up within the university setting. So for me, taking away from it, it was just a very accurate depiction of what an emergency situation would look like in the future. The second thing that I want to talk about is the GLADA business meeting that just ended yesterday at noon. I think there's a lot of things that I took away from the meeting one of the biggest and best things that I did was listen to a talk by Douglas Casa, who did a lot of the position statements on heat stroke and prevention of heat illness and acclimatization. In essence, it was very good about what we can do to prevent and what we should be doing to treat. And to be honest, I wasn't a very big proponent of rectal thermometry before, and I didn't really understand how you would do it or why you would do it. And yeah, whatever. I can take the temp wherever. I was very close-minded in that aspect, but basically what he presented on is that we can't really go by the shiver rule for ice passes. It's basically saying that if you aren't assessing core body temperature accurately, you could technically pull them out 30 minutes later if they were at a 110 or 112 body temperature, and they'd only be at 106, which is still above and characteristic of heat stroke. So if you're not cooling first, and then you're not taking a body temperature and not getting them back to below 104, it takes 45 minutes before they even begin to start cooling in the hospital. And by that time, you've increased the patient's likelihood of death by a significant amount. So for me, it really was a big takeaway that wherever I go next year, I am going to be a very big proponent of rectal thermometry. And then the final thing that I want to talk about is that over the past 3 weeks, we've done a number of SIPs. So I've completed the SIP 4.1, 4.2, 4.3 evaluation, therapeutic modality, and rehabilitation of an athletic injury, and that is approved by Connor Burton. And then I've also done a psychosocial technique in dealing with a patient who had an ankle sprain that for him took approximately 6 weeks to come back, and then after returning was never feeling the same and never felt like he had full ability. So it was a lot of reassurance, and then also trying to understand where he's coming from and try to present him with evidence that we were not being truthful and forthcoming, and we were giving him the best evidence based on what we were seeing. And then from this 3-week period, I kind of have 2 takeaways. Number one was just that the low number of hours was a decreased patient load. So for me, it was more so that A, I was going to GLADA, and B, that the week before GLADA, I couldn't miss a lot of class because I had numerous tests and quizzes, and that the Missouri Valley tournament was in St. Louis, so I was unable to travel for that. So it was really based on about a week and a half's worth of hours this 3 weeks. And then secondly, this is kind of a takeaway from GLADA, is that I am not necessarily as competent in my emergency skills as I would like to believe I am. This is really evident in the femoral traction splints and the femoral pole traction splints. So at GLADA, the last session of the learning lab was basically these 2 skills, and although they are very uncommon in the athletic training setting, pole splints have a very unique way that they could be used in athletic training, as in they store relatively small, so they could be carried in a kit, and they kind of expand to then use traction and decrease patient pain if there were to be a femoral break. It's relatively straightforward, and can be performed completely by one provider. And then the real thing with that is just that I'm just very uncomfortable with the whole use of both of those. So from that was really just making sure wherever I go next year that I'm comfortable with the emergency equipment, so that when a bad situation happens, because it's more of a when and not if, I'm prepared for the situation by at least knowing what the equipment does and how it's best utilized, so that we can give the patient the best care that they possibly can receive. This has been the clinical statement number 3 reflection video. My name is Robert Pollock, and I will be collecting data over the next 3 weeks to continue to establish a worth model for athletic training services.